Welcome to country. I would like to acknowledge the Bidjigal people who are the traditional custodians of this land that we meet on today. I would like to pay my respects to elders both past and present, and I would like to extend that respect to other Aboriginal people here today. Good, so welcome everyone to yet another GP Shared Care meeting held twice a year. They are evidence of the significant cooperation that does occur in the maternity care sphere, and we are very grateful to the organisers. We are very grateful to you turning up to this. Now, just from my perspective, clearly I wish you all a very good afternoon of learning. You have some excellent speakers this afternoon. We've got Dr. Madeleine Sheppard, who is a newer staff specialist and is doing fantastic work in maternity care and has really taken up the thorny and difficult area of terminations very well, and she'll be talking about that. And then you have Helen Barrett, who is an absolute jewel in the sphere of obstetric medicine and heads, such a solid obstetric medicine service. We learn all the time from them, and they just offer excellent care, appropriate care for women in pregnancy. Then we've got Katy Hunt, who is just a tireless champion of lactation. She's always at the hospital later than I am in the evening, hammering away at various details of her excellent teaching program. So it's a great lineup of speakers. Now, just from a general perspective, it's just been a very good week for the hospital. There has been one of these newer accreditations. It's called a SNAP accreditation, where they don't give you much notice. And a lot of work has been done to essentially make sure that we're doing all the right things by the national standards. And we had the feedback from the surveyors at the end of there, and they were glowing in their compliments, right? Now, that's due to the hard work of our excellent general manager and the executive that she leads. And they were highly complimentary, particularly of the level of cooperation and collaboration in the hospital. Now, we know that things aren't perfect, and we are always made aware of it. But this was a genuine accolade, and that hasn't always happened with these, right? So I just wanted to pass that on to you because you are part of that as well. Now, the other thing, what's been looming large this year has been the birth trauma report. It's a very complex issue that we're dealing with there. The spectrum of problems, that were, presented and cases that were presented in that inquiry, in essence, mind-boggling. It's very difficult to deal with the whole lot of it, right? A number of initiatives are going on in the hospital. From your perspective, you often find out about these traumas before we do, all right, because they occur. And if you do, clearly we want to be part of, dealing with such situations and also trying to prevent it. There is an initiative for a debriefing service. We've got a specific midwife dedicated to that. As you know, I'm only too willing to be contacted directly if you have concerns about care that has arisen, and often it does arise after the fact, because in the first week after the birth, the first 2 weeks, women are just not ready to discuss those things. You know this better than I do, and you as GPs are often, are in a far better position to receive, to detect these things, and you receive almost the full weight of it and you get a clear idea. And clearly we want to know about that. We want to cooperate on this front. We had 2 excellent presentations on this recently, one from our Director of Perinatal Psychiatry, Meredith Stone, and I would like to be able to share that presentation with all of you. It had some excellent insights about it, and then another excellent presentation about trauma-informed care from, our wonderful social work department. These were highly informative, they were concise, they had practical messages. So that's how we want to proceed with that. That's all I'll say today. Again, thanks very much for turning up, and I hope you learn and enjoy the afternoon.
Thanks, Andrew. My name's Helen. I'm a GP in Surrey Hills. I'm one of the GP representatives on the Royal's Antenatal Shared Care Committee. So there's some sponsors you might have seen out there at lunch, and we really appreciate the support of our sponsors at today's event. There's Besson's, IVF Australia and Randwick Women's Health. The session's been approved for 3 hours of RACGP as an education activity. So that evaluation survey is really important to do at the end. There's also the antenatal share care CPD, that this counts for 6 CPD points. You need a total of 12 every triennium. So you're getting half of that today. There's a calendar of events. So there's a few more things that are up and coming this year. Of course, you can always check the website or the emails when they come out. And then just to let you know a couple more things, there's a clinical placement. So where you can come in and brush up on your clinical skills with one of the obstetricians here at the hospital. So the 4th of December, if you want to register for that, then Hui Ling, who's here, if you can email Hui Ling, and that's the email address there. So yeah, 12 antenatal shared care points. You can get some external educational activities, face-to-face or online, that's fine. CESPN will contact you if you need to make up points before the triennium is over, before you get taken off the list of shared care providers. CESPN does not have access to your RACGP record, so bear that in mind. So you need to forward any supporting documentation if you do external activities to the shared care ANSC at cespn.com.au. So I'd like to introduce our first speaker today, Dr. Madeleine Sheppard. Maddie's a newly qualified staff specialist in O&G at the Royal Hospital for Women, having completed fellowships in the UK and at the Royal Hospital for Women in advanced laparoscopy. Maddie works across a range of obstetric and gynaecological services at the Royal and, as Andrew said, leads the newly established termination of pregnancy service, and she'll be seeing women privately for gynaecology in the eastern suburbs from next year. So welcome, Maddie. Yeah.
Thank you so much for all coming along. I just wanted to echo Andrew's sentiments in how important it is for us to have collaborative care with you. And I know that already in terms of the termination service, there's already been some referrals coming through, and we've been in contact with a few of you in the room with that. So partly today I'll be running through what the service at the Royal is looking like and doing otherwise mostly a bit of discussion around medical termination of pregnancy and just some troubleshooting in regards to that. So plenty of time for questions at the end. Similarly, I'm very happy to be contacted at any point in time as well. So I'm always happy to chat if you're seeing women in the community and you just need a little bit of guidance about how to manage them or whether they can come to see us. So I thought, first of all, there's obviously been a lot in the media recently about termination in Australia and in the US, and I thought I'd just run through what are the current legalities in New South Wales. So currently, termination of pregnancy is legal in all states and territories in Australia. This is a change for New South Wales in 2019. There are differing laws between each state, but it's fairly subtle differences. So what this means is that women and clinicians are no longer at risk of prosecution, and doctors in New South Wales can perform abortion up until 22 weeks without any further restrictions. After 22 weeks, it's regardless of indication, a second clinician is required to agree on that decision and needs to be managed in an accredited facility or hospital. This also legislates that medical practitioners who have a conscientious objection must either provide information to patients about how to contact or locate a medical practitioner reasonably believed not to have a conscientious objection, or to transfer the patient's care to another practitioner or health service where the termination can be performed. Meanwhile, in the US, unfortunately, with the overturning of Roe v. Wade in 2022, there's some significant changes happening in that space. And this is just a basic graphical representation, the red states being those that have completely banned abortion, the green where it's legal, and the orange, there's certain restrictions, a lot of them actually only allowing up until about 6 or 12 weeks of pregnancy, some up to 18. So in terms of the magnitude of the issue in Australia, it's significant. So for Australian women, about 1 in 3 to 1 in 4 women will have an abortion in their lifetime. So this affects a significant portion of our patients. There's about 80,000 terminations of pregnancy that occur each year in Australia, and the vast majority of these are below 14 weeks, with only 10% above this and 1 to 2% over 20 weeks. MS2 step has been available since 2012. So if we look globally, in countries where both medical and surgical termination of pregnancy are offered, it's about a 50-50 uptake between the two. In Australia, the stats are that there's about 30% that are medical, so the vast majority are still being performed surgically. Fantastically, you no longer need to be a registered prescriber, as I'm sure you know, and there are also midwives and nurse practitioners who can prescribe as well. Now, in terms of counselling, obviously with termination of pregnancy, this is a significant decision in any woman's life, even if she feels very sure of her decision. And I'm not going to teach you how to suck eggs about how to counsel patients. You're obviously experts in that. But I think the first thing is to try and explore the reasons for that particular woman, why she's seeking termination. I have found that it can be helpful to avoid that coming across as a potentially judgmental sounding question, to really acknowledge that at the start of the consultation and explain to the woman that, you know, there is no particular reason that is right or wrong for the decision that they might make, and that they can be supported in that decision regardless of the reasoning. But that in order to counsel them through it, it can be helpful to really explore what's driving that decision for them as an individual. Obviously, this needs to be a non-directive counselling approach. And I think the first thing as well is to realise in yourself whether you feel confident on that day with that patient, if you're a conscientious objector yourself, early, and to refer on as appropriate. And that's completely okay. So I think it's really important that everyone works in this space within, you know, what they feel comfortable with. So know who's around you. If you do want to refer to us, to refer to another GP, refer to a private service, so that you can hand that information on to the woman early, because certainly what we see through our service is women who've kind of been moved on to someone else and not really known how to navigate the system. And certainly when you look online, it's really unclear for women where they can go and who to turn to. There are some really useful resources through particularly things like Children by Choice and the Royal Women's Hospital in Melbourne, and they've certainly got some very helpful online decision-making tools. I've certainly found these helpful, and they're sort of things you can print off and go through with the woman, particularly if they're feeling really overwhelmed about weighing up, you know, decisions, factors that might be leading them towards continuation or terminating the pregnancy. Exploring the risk of coercion is also really important, and this can come across in fairly subtle ways. So I think speaking to women about who they've already told, who are they thinking of telling, and then going through each of those people and finding out how would that person respond, how would that make you feel, will that change your decision making? Obviously, this is a time where women can be a bit unstable in the rest of their lives, not necessarily, but just exploring the issues of potential domestic violence, substance use, childcare, all of those sorts of things, other pressures. And it's a good time to have a chat about medical versus surgical options. So I've just popped up a bit of a graphic representation about the options in terms of medical and surgical abortion. So essentially medical is an option at any gestation, while surgical is, we usually would perform from about 7 weeks rather than earlier. And in some areas up until 24 weeks. And I'm happy to send the slides around at the end too. So, sorry, bring it back. And I guess the other point to make there, similar procedurally, but dilatation curettage being at earlier gestations and being via just suction, while dilatation and evacuation is a more destructive procedure. I guess a few key points to talk through with women who are trying to make the decision about which route might be best for them. For medical, it can be helpful in that a lot can be done via telehealth. Women can avoid an anaesthetic or a procedure. It's lower cost and they can do it within their own home. With surgical, there's no follow-up required, while with medical, there is requirement for follow-up. Less ongoing pain and bleeding, a more sort of defined time frame for completion, and a slightly lower chance of retained products of conception, though this is fairly small difference. It's quite low with both. And obviously not needing to see any pregnancy tissue or sort of experience that. In terms of MS two-step, this can be used up until 63 days in the pregnancy, so that's 9 weeks and 0 days. It's $31 with an authority script. Through a lot of private providers, so MSI, etc., the minimum cost can be up to $300 as well as an ultrasound, so it still does become expensive for women. It's important to think about co-prescribing analgesia, antiemetics, and thinking about contraception at the time that this consultation is happening. Obviously, time limiting. Routine antibiotic prophylaxis is not required. Now, efficacy I put down as 96.7%. That's in terms of the risk of ongoing pregnancy. So a little bit about each of those medications. So mifepristone is a 200 milligram oral tablet. It's a progesterone receptor antagonist, which basically stops the pregnancy growing. It disrupts attachment of the pregnancy. It helps to soften and to dilate the cervix, and it increases uterine contractility when misoprostol is given. Side effects from mifepristone are fairly rare. So usually when women take this 36 to 48 hours before their misoprostol, they're usually not feeling very much at that point in time. Once they take the misoprostol, this is for tablets which are held just buccally, so on the gum. This is a synthetic analogue of prostaglandin, and this is what initiates those uterine contractions. The side effects with misoprostol are common, so particularly things like nausea and vomiting. If the tablet's swallowed rather than used buccally, that's worse, and similarly with diarrhea. It's quite common to have a low-grade fever within the first 24 hours, but it should resolve after that time, and there's a small chance of skin rash. Most women can use MS two-step, but I guess there's a few contraindications that are important to think through. So we need to be fairly confident that there's not any suspicion of an ectopic pregnancy. They shouldn't be at any increased risk of bleeding with anticoagulants or hemorrhagic disorders. Women with chronic adrenal failure or long-term corticosteroid therapy are not appropriate, or if the woman has lack of access to medical care, so she doesn't have someone to take her into hospital, or if she lives a long way from care or children in her care, etc. IUD in situ, again, that should be removed prior to using medical management, or if there's any uncertainty regarding gestational age, you want to be clarifying that with ultrasound prior. So again, before prescribing, counselling is important, detecting coercion, ambivalence, and making sure that they're a suitable candidate. It can be used in women who've had a previous caesarean section, women pregnant with twins within the same gestational age cutoff, and women who have any uterine abnormalities or fibroids. And actually, they're probably better candidates for medical if they were to have uterine abnormalities, fibroids, etc. Formal ultrasound, it's not an absolute requirement, but I would recommend it strongly. I think the instances where you You may be very sure about someone's LMP, if they've had IVF, those kinds of things, and you're pretty confident that there's no signs of ectopic, it may be appropriate, but I would err on the side of doing one because I know how often we've all seen women who think that they're one gestation and are quite different. There's no need to do bloods. So you don't need to do rhesus status, you don't need to do anti-D for women less than 10 weeks, which is this group. And obviously think about opportunistic screening for cervical screening test. STI screening as well. So routinely women should be offered chlamydia and gonorrhea screening, and this can be done via self-collected vaginal swab, and this is preferable to a first pass urine. You don't need to delay waiting for results. If you are suspicious that they are at risk of infection, you could treat them prophylactically at the time. They should also have screening for HIV, syphilis and Hep B ideally. And you can consider on a risk basis Hep C, Trichomonas, Mycoplasma and BV. In terms of hormonal contraception, obviously you are all very up to speed on prescription of contraception. So again, I'm not going to labour on this. I'm just going to talk about the points in relation to timing with MS2 step. But ideally, we try and commence at the time of prescription or have a plan in place. There's no benefit in waiting for resumption of normal menses, and fertility can return as early as 2 weeks after medical termination. So it's important to make sure that women are aware of that. In terms of efficacy, if any of the hormonal contraceptives are commenced within 5 days of termination, there's no additional contraceptive cover required. If it's commenced more than 5 days, they will need additional contraceptive cover for 7 days. So that's usually going to be your barrier contraception. In terms of when you can start each of the common agents, so an IUD can be inserted when the medical termination is deemed complete, and I'll go into that in a little bit more detail in the next couple of slides. With the combined pill, it can be started the day after misoprostol. Implanon can be inserted on the day of prescribing, so before you've even started the MS2 step, and the same with Depo-Provera. The caveat with Depo is that it can, being a progesterone, it can interfere with the effect of your mifepristone, so it may slightly reduce the efficacy and thus the efficacy of the medical termination. However, that just needs to be balanced against the risk of whether the woman will actually follow up, as the risk of the change in efficacy is quite minimal. So I guess really important to be able to talk with women about what they're going to expect, because this is going to drive their decision making about whether to go down the medical or surgical route in a lot of cases. So within 1 to 4 hours of taking the misoprostol, we'd expect the bleeding to commence, and it can be quite heavy. So this usually would last for a couple of hours and then become sort of lighter over the next 10 to 16 days. We would recommend that women present to ED if they're saturating 2 or more pads per hour for 2 hours or passing fist-sized clots, and obviously any signs of hemodynamic instability. The other thing to mention to women is that if they haven't experienced sort of a clinically significant bleed within the first 24 hours, that they should be in contact and a discussion had about whether to give a repeat dose of MS2 step if they're still within the 9 weeks. Or whether to go down the surgical route or investigate. Pain can be mild to severe. We'd usually recommend giving a non-steroidal as the most effective agent about 30 minutes prior to taking their misoprostol, and you can add in some codeine as well if needed. They'd expect period-like cramps for a few days afterwards as well. With the misoprostol as well, quite common, as we mentioned, to get nausea and vomiting, so prescribe an antiemetic at the same time, and this should resolve within 24 to 48 hours. Breast symptoms from pregnancy would be expected to resolve within 1 to 2 weeks. Now, this is from a large observational study in Australia looking at women who had medical termination, describing what their experience was. So about 50% of women described having heavy bleeding, and about 40% had moderate bleeding. Pain and cramps were severe for about 37% of women and mild to moderate for about 60%. If we then look at the same study, they looked at how this compared to what women had expected prior. So for about 50% of women, it was pretty similar to what they'd anticipated, while about 30% they found it better than they'd thought. Similar with pain and cramps, 45% as expected, with about 30% finding that it was better. And then overall experience, you can say. So in terms of complications, they're quite rare. So the most common thing is incomplete abortion, which is about 4%. And this is slightly higher risk in women who are older or at more advanced gestational ages. Then infection, risk of hemorrhage requiring transfusion or continuing pregnancy is about 1%. This is pretty much the same information, but just to give you a bit of an idea about medical versus surgical, they're really overall fairly similar in terms of complication rates. I guess there is a slightly higher chance of incomplete abortion, continuing pregnancy, or incomplete abortion, but the rates of heavy bleeding requiring transfusion or infection are actually quite similar. So follow-up is a requirement of prescribing MS2 step. So this should be performed about 2 to 3 weeks after mifepristone dosing, and it can be done via telehealth. The goals essentially at this point in time are to rule out ongoing pregnancy and to identify signs of incomplete termination, and to exclude complications such as infection. It's also a really good time to review if they've started a new contraceptive, how they're finding that, or to initiate or insert an IUD if you haven't already. And obviously an emotional assessment at that point in time. So this is a little bit of a busy slide, but I've just put up about confirming completion, and there are a few different ways that we can do it. In green are the 3 options that are recommended. The 2 yellow options are not really routinely recommended. So symptom resolution may be enough. So you'd want to hear from the woman that she had clinically significant bleeding 24 hours after dosing of misoprostol, and then cessation of bleeding and cramps by 3 weeks, and pregnancy symptoms. I think you have a really low threshold at that point in time to think about doing an HCG, and you might decide in your practice that you do that for most women. In terms of beta HCG confirmation of completion, you need to do a baseline HCG within 72 hours of mifepristone, and then we'd look for an 80% decline on the repeat HCG, and this should be done at greater than 7 days, so often somewhere in that sort of 8 to 16 day window. You can also use a low sensitivity beta HCG, and that's what we're doing through the clinic at the Royal, but you probably don't have access to these in your clinics. We had a bit of trouble sourcing them, and the benefit of these is that they only detect HCGs over about 1,000. So the usual high sensitivity HCGs will detect anything from about 30, and that can remain positive for weeks and weeks, by which time you've kind of missed the boat on detecting a problem. In terms of pelvic ultrasound, so if we've got a pelvic ultrasound that is showing an empty cavity, then that's very reassuring. But the problem with doing routine ultrasound is that there will often be findings that are unclear, and it can lead to overtreatment in this group. So it's not routinely recommended, but certainly if you were concerned at that 3-week mark that someone was having ongoing bleeding, symptoms, cramping, then that would be an appropriate investigation to do at that point. So I thought I'd just run through a little bit of common troubleshooting. So someone who's had no or minimal bleeding within 24 hours of misoprostol, if you've not already done an ultrasound, I would be doing that to check that it is indeed an intrauterine pregnancy and we're not missing an ectopic. You can offer a repeat dose of MS2 step. Again, they still need to be within 9 weeks or 63 days, or refer on for surgical termination. If the woman has persistent bleeding at 2 to 3 weeks, I'd be suspicious of incompletion, and so you'd be considering doing an HCG and ultrasound. If there is a small amount of product left, you can offer the woman conservative management and follow up to see whether this does expel on its own over the next couple of weeks. or often these women will require referral for surgical management, so a DNC. Ongoing pregnancy, so we said there's about less than 1%, but we would usually recommend termination in this context as there's a small risk of teratogenicity from the medication. So that's usually skeletal abnormalities, skull defects. So this would usually be done by a surgical termination. If the woman did wish to continue, then just refer on so that we can see them and offer scans through MFM. Again, anti-D not routinely required for medical termination before 10 weeks, but for surgical termination at any gestation, we would usually give anti-D. So I thought I'd just run through a little bit about surgical termination as well. So we usually would offer this from about 7 weeks. The reason we prefer not to do surgical prior to this is an increased chance of missing the pregnancy, so a higher chance of ongoing pregnancy. There is increasing surgical risk with advancing gestation, so in particular risk of perforation or of hemorrhage. The gestational cutoffs at the upper limit are variable between different clinics. So at the Royal at the moment, we're going up to about 16 weeks, but this is a bit variable depending on the woman's parity and other risk factors and how desperately she wants surgical. So if that's a limiting factor for her, please just discuss with us. Some private clinics do go up to all the way to 20 weeks. In the private sector, it does very quickly get very expensive for women. So the cost can range from about $700 to $3,000 with a Medicare rebate of about $400. One of the benefits being that we can put in an IUD at the same time though. So in terms of what to expect, minor procedure, day only, usually performed under GA or sedation, minimal post-operative pain and bleeding, mild nausea and breast symptoms, again, we'd expect to resolve within 1 to 2 weeks. Complications, so quite rare, but risk of retained products, infection, which we would routinely screen or treat prior, perforation, hemorrhage, cervical injury, cervical stenosis, small risk of future cervical incompetence and preterm birth. That's not 100% confirmed, but a possible risk, and a small risk of Asherman syndrome. Women are often really worried about whether or not this is going to impact their future fertility, and the evidence suggests that it's very, very uncommon that it would cause any problems for that. So to reassure them. So I've just put up a slide here that just gives a little bit of a summary about the private clinics around our area. And this is as of recently, speaking to each of them. So I will send the slides around, but it just gives you an idea about gestations for surgical termination in particular at different sites. So at the Royal, in terms of our referral criteria, at the moment it's fairly narrow just because we're getting started and we just need to be able to manage what's coming through the door. But at present, it's the main thing is that it needs to be within our local area, so by postcode, and the woman needs to have some other area of need, so complex medical or social needs, vulnerability, young or adolescent, financial barriers, or that they've not been able to access care somewhere else. So we're not going to turn away anyone who's not been able to access care somewhere else. So if in doubt, give us a call. I've listed our service coordinator phone number there as well, which will be made available to you, and always feel free to give us a ring. We are happy to see women prior to them having made a firm decision. So if they're sitting in front of you and they can't quite decide, we're always happy to see them and have a consultation. Similarly, in terms of aneuploidy or issues on scan, etc., they should be referred via MFM. So referrals are via e-referral to the termination of pregnancy clinic, or you can call the clinic coordinator number or email us. Women can self-refer as well via that same number. And we've accepted referrals from EDs, other hospitals, DV services, Kirkton Road, Child Protection Unit, Sexual Assault Services, the lot. So in terms of referral, we would love for women to have had an ultrasound prior. So just to confirm it's intrauterine and the estimated due date. Some basic history in terms of their medical, obstetric and surgical history and psychosocial scenario. We would like bloods as well, so blood group and antibody screen and antenatal serology, low vaginal swab and chlamydia and gonorrhea testing. Again, we can do these investigations, and for women who are struggling to get an ultrasound done in the community, again, just give us a call and we can see if we can organise an ultrasound while they're in seeing us. So in terms of how the service runs, we're just about to move to weekly clinics. It's consultant-led. We have a dedicated coordinator who carries a mobile phone between 8 and 4:30 Monday to Friday, and that's a phone number that women can contact as needed. We're very closely linked with an amazing social work team who are really, really fantastic with these women. We also work closely with Aboriginal liaison and psychiatry as needed as well. We also offer medical management after 9 weeks. So if a woman wants to go to have medical management, but she's passed the cutoff for MS2 step, again, we can see them and do that in the hospital. So I'll just very briefly go through medical termination after the cutoff for MS2 step. So this is done by inpatient management, and it's a multiple dose misoprostol regime with mifepristone prior as well. Prior to 16 weeks, these women are managed on the ward, and after 16 in the birthing unit with one-to-one care. The main consideration in this kind of group is the risk of retained placenta. So about 1 in 5 women will have a retained placenta in the early second trimester and need to go to theatre for a manual removal. Beyond 20 weeks, there is a legal requirement for registration of the birth and death of the fetus with birth, deaths and marriages. And women are required to engage a funeral director after this time as well. Unfortunately, this does end up being quite expensive, $1,000 or more in most cases. But women are able to access maternity leave, and they can access bereavement payment through Centrelink, which can be about $4,000 to help cover that. As I said, second clinicians required beyond 22 weeks. And at the Royal, we would offer feticide from 22 weeks and recommend it, or it's required from 24. Again, a busy slide, but this just kind of depicts what happens at different gestations at the Royal. I've just included a couple of resources here for pregnancy choices counselling. There is one Queensland reference in there as well, but they have been known to speak to women and they are quite good. There's good online resources through these things, but also phone lines that women can call and speak to as well. So I've just included as well some online training resources, and I believe RSCGP has something as well. But yeah, I've just listed up there what's available. That's it. Any questions?
Dealing with medical abortion.
Yeah.
No less traumatic, I imagine, for many kids in a way. Surgery is surgery, but nonetheless, psychologically, I think it's no less traumatic. Anyway, I'm trying to touch on it.
I'll repeat the question. Oh, yes. I'm just going to repeat the question. So the question or comment was just in regards to telehealth and whether that is an appropriate way for women to be managed with medical termination. And I would agree with the sentiment on that. Like, I think certainly, if possible, seeing the woman face-to-face is preferable. And I think largely this is being used for women who are in regional and remote areas who may not have access otherwise. Yeah. Sorry, there was a question up there.
Is a GP, is it looking at GPs prescribing that into
the MS2 step? Yeah, so just asking about GP prescription of MS2 step. So yes, you no longer need to be a registered provider. You used to need to do the online course to register to do that, but it's now opened up, so there's no specific requirements. So yes, we're encouraging GPs to get on board with that, and obviously we're very happy to discuss if any support's needed in doing that.
Termination, but threatened miscarriage in those early weeks is still required.
Is that via the Blood Authority document? There's this is, to be honest, with threatened miscarriage, I usually wouldn't give anti-D in the first trimester. With a complete miscarriage, we would. There's been a bit of change in the guidelines around that, and actually a few of the guidelines don't quite match up with one another. So what RANSCOG says versus what the Blood Authority says don't always match up. So certainly some of the guidelines would suggest that for a threatened miscarriage, you don't need to give anti-D in that early first trimester.
Is there a contraindication to giving anti-D?
There is no contraindication to giving anti-D other than if someone already had antibodies formed. But I guess it's trying to do it where it's needed and not at other times, in terms of resources and also in terms of getting the woman back. In terms of the surgical versus medical, I think the idea is that there's probably a little bit more crossover of any potential fetal cells from the abrasion from the surgical procedure itself, making that a little bit higher risk than the medical routes or a miscarriage. Yeah. Yeah.
So you're saying that we can now send an 18-year-old just with an unplanned pregnancy who can't afford a private termination to your clinic?
Yeah, so if they can't access care privately because of financial barrier or whatever else, then yes, we would be happy to see women. Yeah, they need to fall within our postcode.
Yes.
Yeah. Yeah, so the question was, what's the wait time to get into the service? So we are trying to see women within a week, and I would say we almost always, I can't say for sure, I think we've always met that. Yeah. Not necessarily they might not get the abortion actually done within that time. They might slightly go over that, but we definitely see them for a consult. Yep, at the back. Yeah. Yeah, so it's an authority script, and you just write MS2 step on it. And there is sometimes issue with which pharmacies are actually stocking it. But I believe our pharmacy here at the Royal, like downstairs on the ground floor, would have it. So that would be somewhere to direct women. Yeah, but it's just a simple script.
There's a few questions online as well. Someone's asked, do you know what the average age for a termination of pregnancy is? They had heard it's between 35 and 50.
Yes, I haven't looked at it recently, but certainly in some of the reading that I've done in the past, it is later than what we would expect. So actually, I think the stereotype is that this is young women who, are not in a stable relationship, all of these kind of factors. But actually, when we look at the numbers, it's often for women who are a bit older, might be in a stable relationship, and it might be for more family planning in between other children within that relationship. So, yeah, I mean, abortion is for 1 in 3 to 1 in 4 women in Australia. So it's everyone who's affected by this.
There's another question just about medico-legal issues. What should we do if they don't come back for follow-up after medical termination, bearing in mind that they may live with parents or family who don't know about the termination of pregnancy?
So can people online hear your question? Yeah. So look, I think it's difficult in terms of what to do in that scenario. I think it comes back to the initial counselling with the woman and that she's aware of the potential risks. I think that you need to be cautious about contacting women, particularly leaving messages that might indicate that they're having an abortion, anything like that. We need to be really conscious of. I'm routinely asking women in the clinic whether they're happy for a GP letter to be sent as well, because not everyone's happy for that. So I think, it's important to try and reduce the barriers for someone to follow up. I know some GPs are getting the patient to pay for their follow-up if, they're charging a gap to pay for their follow-up in advance, so that when the patient, there's no additional barrier to getting them back. But it's complicated.
There's one more. Have you heard that there's a shortage of copper IUDs at the moment in pharmacies?
There's a shortage of copper IUDs, particularly the T devices. If anyone has any updates on where to get them from, I'd love to know though. Yeah, we've had the same problem.
And then one more. Do you know how much it costs privately for people without Medicare at the women's hospital if they come to the clinic here?
That is a good question. We've definitely been through that process. I can find out for you. I'm not sure what it ended up being.
Can you please explain when you use copper versus urina?
Yep. So the question was just... in this context. Yeah. So the question was just in regards to using the copper IUD versus the Mirena in this context. I would say it's pretty similar to outside of surgical termination or medical termination. They're both appropriate to use. I would counsel the woman about sort of the long-term benefits and risks of each and make the decision based on that. I guess the other thing is just considering when you're putting that in and if there's any risk that they may have had another pregnancy. So say you've done a MS2 step and they've come back to you at 4 weeks afterwards, for instance, and they've been sexually active without barrier contraception, I'd be considering using a copper IUD just because there's a risk that they've fallen pregnant again, and that doing a urine beta HCG is going to be a bit confusing as to whether they are or aren't pregnant. So, yeah. Otherwise, either's fine to use.
There's one more online. It's who can people ring if they have problems after taking the MS2 step, after hours or at the weekend if they're not in this postcode?
I think I don't think there's anything in particular that's set up as an after hours service for that. So if it's an emergency, they'd need to present to an emergency department, and if not, be waiting until business hours in order to contact the appropriate service.
Thank you for that. We're just going to wait for our next speaker to arrive. We're running ahead of schedule, which is unusual. So give us 5 and we'll get Dr. Barrett here. Oh, hang on. I'm getting a bit in my...
There is also an MBS code for pregnancy options counselling, which is 81000. So you can bill via that too.
So our next presenter is Dr. Helen Barrett, and Dr. Barrett is Director of Obstetric Medicine at the Royal Hospital for Women and is an obstetric medicine physician and endocrinologist. She's a conjoint associate professor at UNSW and undertakes research in diabetes and metabolism in pregnancy. She's a past president of the Society of Obstetric Medicine Australia and New Zealand and an author of national guidelines, including those regarding management of hypertension and diabetes in pregnancy. Please welcome Dr. Barrett.
Hi, everybody. Can you hear me okay?
Can you
speak a bit
loud?
How's that? Better?
Much.
All right. So I'm Helen Barrett. I've been given a broad remit, and I understand you've got my slides. We're going to, as we go through, if you have questions, ask them at the time. I think we've got time to do that. Okay. So in the slides, I've got some suggested references and that sort of thing for you to have a look at as well. So what we're going to do is we're going to talk about pre-gestational diabetes, type 1, type 2, and concentrating mainly on the preconception period of time. Talk a bit about the GLP-1 agents and pregnancy planning because it comes up all the time at the moment, in our general population, and then touching on bariatric surgery. So these are the best resources, I think, for pre-gestational diabetes. There's a short synopsis of the ADIPS guidelines that's available free online, or you can go to the ADIPS website and get the full-length document. There is a 2-hour online course done by the NDSS that's accredited by the RACGP. And then I've just got down there a short review article in the Australian Prescriber that's quite good as well. I'm assuming they have the slides, right? Do they? Do you guys have the slides? No, you can have them. I'm happy to, yeah. Okay, perfect. All right, so introducing this lass who's 34. She's got type 2 diabetes. She's had it for a while, 16 years or so. Her HbA1c has always been above 8. High BMI, hypertension, hyperlipidemia, some early retinopathy, family history of diabetes and kidney disease. And at the moment, she's on a number of medications, actually, most of which we're going to be worried about in pregnancy. So the reason I chose a woman with type 2 here is that the frequency of type 2 in the obstetric population is increasing. And the really important thing to remember is that they don't do better than the women with type 1. They actually do a little bit worse often. So this is just looking at some general data. Duration of diabetes is often shorter in women with type 2, but not always. We do see an increasing number of women diagnosed in their teens or, around about the age of 12 and above. Obviously, usually a high BMI. And here you can see actually in both groups that perhaps their preparation for pregnancy, generally speaking, is not great. Only about half of the women with type 1 are on folic acid. 20% of the women with type 2. And then you look at the medication use leading into pregnancy isn't too bad on the whole. But their HbA1c average is about 7.6, so 60 is roughly 7.6%, a little bit better than that with type 2. But there's a lot of them that don't, there's only a small percentage have an HbA1c less than 6.5%. And the target pre-pregnancy is less than 6.5% if you can do it without the mum having lots of hypoglycemia. And here we've just got some of the pregnancy outcomes. So timing of delivery is roughly 37 to 38 weeks in both groups. And that's the expectation they should be going into pregnancy with. They will not be making 40 weeks of gestation. The rates of large babies are relatively high in both groups. Special care admission, congenital anomaly. What I haven't shown you here is, data on the rates of ischemic heart disease and that sort of thing, which again is relatively high in the population of women who have developed diabetes as a teenager. And then they're coming to pregnancy 15, sometimes 20 years of diabetes later. And we know that people diagnosed in their teens spend most of their adolescence usually in young adulthood with poor control. So they often have complications of their diabetes before they get pregnant. So what we know about type 1, type 2 diabetes is that the pregnancy outcomes directly relate to the HbA1c at the time of conception and the glucose control through pregnancy. And there's graphs. You can look them up. You can point them out on, it's as easy as Googling it. If their glycosylated hemoglobin, their HbA1c is about 7%, then their congenital malformation rate's about 7 or 8%. And remembering that the normal rate of congenital malformations is about 3% for a major congenital malformation just in the population. And you can see here that by the time the HbA1c is 10%, then you're starting to hit up towards that 15, 20% mark of congenital malformations. So when you're starting to talk to women about planning pregnancy with their pre-gestational diabetes, I guess the comments I'd say is don't forget they need all the normal stuff. It can be really distracting when a woman has a medical condition. You start focusing on that, but you've got to do all the normal stuff that you usually do, and don't forget the genetic carrier screening. So what do you have to think about? You have to assess them for their current complications. And I've highlighted here in red eye because I think often people underestimate the difficulty that women get into with eye disease during pregnancy. If you've got mild retinopathy, non-proliferative diabetic retinopathy, then your chance of progressing up at least one grade is about 15-20%. Up 2 grades of retinopathy is about 10%. So don't underestimate the eye disease. Make sure it's up to date and that they've been reviewed. Don't forget about the cardiovascular and also dental. Most of the women in our catchment have fairly good dental care, but dental assessment's important as well. And then the usual things, and these are in the guidelines. What's their kidneys doing? How much protein do they have? What's their liver? Do they have fatty liver? What are their lipids like, HbA1c, etc. So if we go back to this woman I've mentioned at the beginning, who's 34 with type 2 of reasonably long duration, what am I starting to think about? I'll be thinking about looking at those bloods and urine. I'd be thinking about her weight, her hyperlipidemia. There's the Get Healthy program in New South Wales for some weight support, or a dietitian doing some exercise, and trying to get her weight down a little bit prior to pregnancy. Thinking about her hypertension. Do I think it's well controlled? Do I need to assess it with a 24-hour monitor or not? Am I happy with it? What's her urine protein creatinine ratio like? It's really helpful. And I know that we normally use albumin to creatinine ratio for diabetes outside pregnancy, but inside pregnancy, when they come at 24 weeks with their hypertension, the first thing we wonder about is what was their urine protein creatinine ratio either before or at the beginning of pregnancy? Was it high already? Because that changes whether I think they've got preeclampsia or not, right? So it's really helpful to know what the urine protein creatinine ratio is just on a spot urine. Retinopathy, I said, get an optometry review, dental check. Do they have sleep apnea if their BMI is really high? Sleep apnea matters. It's associated with increased preeclampsia in pregnancy and preterm delivery in small babies. Cardiac assessment. Does she have any cardiac symptoms? And bearing in mind with long-term diabetes, they don't always have a lot of chest pain. It might be just exertional dyspnea. So again, in long-term diabetes, erring on the side of having some sort of cardiac assessment, whether that's a stress echo or other forms of assessment for ischemic heart disease. And then think about whether or not you need to look at her liver, looking for steatosis and fibrosis. Medications, folic acid, at least 2.5 milligrams daily, and often 5 milligrams daily of folic acid. Often what I do is have them on a pregnancy multivitamin, which will have the 500 micrograms in it, plus folic acid, 5 milligrams every second day. So they're averaging about 2.5 milligrams daily. Now, the tricky thing then is what do you do with the drugs? So this lady in particular, she's on an ACE inhibitor, she's on a statin, she's on semaglutide. In fact, the only drug I've been continuing into pregnancy with her is her metformin. But the question is, when do you stop it? If you're planning, then ideally you would stop them, transition her to metformin and insulin before conception. A lot of women obviously get pregnant unexpectedly, in which case you would stop all of those at conception. The Ozempic type semaglutide medications, I'll come back to. I'm going to talk a little bit more about those. When to stop the statin and the antihypertensive is a little bit difficult in that there's a balance of risk for an individual woman. So if she's got heavy albuminuria and she's on an ACE inhibitor, I don't necessarily want to stop it for 1.5 years while she conceives. It's easy if she's going to go to IVF. You stop it before she goes for the embryo transfer. But if she's trying to conceive naturally, there is a choice, and it's a discussion between continuing on that medication until very early pregnancy and then stopping it to protect her kidneys for as long as possible, or stopping it prior to pregnancy. And the same thing with the statin. If she's got really high lipids, and particularly if she has a history of ischemic heart disease, then you don't necessarily want to stop the statin for 1 year while she's trying to get pregnant. So those drugs in particular are tricky. You can use them into very early pregnancy, but it's a balance of risks. So it's an individual discussion. If you're being conservative and she doesn't have ischemic heart disease and she doesn't have heavy proteinuria, you stop it before she conceives. What I tend to do is judge the risks and talk about it with the patient. If she's trying to conceive naturally, have her doing really regular pregnancy tests just urine tests trying to pick up when she conceives and stop them as soon as she conceives for the ACE inhibitors, the ARBs and the statins. But that's a discussion, and it can be a tricky decision to make. I've got here on the bottom right of the slide the glucose targets that we're looking for. So before pregnancy, a fasting less than 6 and a 1 hour less than 8.5. And then during pregnancy, those lower numbers that we look for. Now, obviously, the women with type 1 diabetes will often these days be on insulin pumps, but not always. The women with type 2 diabetes will be needing to prick their finger. There's no, unless they choose to buy the CGMS, there's no CGMS subsidy for type 2 diabetes at the moment. So I guess I'm concentrating on preconception in this talk. During pregnancy with the women with type 1 and type 2, we take them through on metformin and insulin. We manage them with antihypertensives that are appropriate for pregnancy, labetalol, nifedipine, methyl-dopa. We get them regular eye review about 3 times during the pregnancy, and they get watched closely. We have a joint clinic with the obstetricians, and they get regular scans and so on. Unless has anyone got particular questions? Yep. Oh yes, please. So, yep, so the question was about referring them preconception. We would be delighted to see anyone with type 1 or type 2 diabetes before pregnancy. You can refer them up to the Royal Women's to Obstetric Medicine for preconception counselling. If it's a woman who needs ongoing management and doesn't have a private endocrinologist, I do diabetes clinic up at the Prince of Wales once a week, so you can refer them up to the diabetes clinic there as well. And then when they get pregnant, they just transfer across from the Prince of Wales to the Royal. And obviously there's private endocrinologists around as well. Other questions about diabetes? Well, if you refer them up, so the comment was about the time it takes to be seen. If you refer them up to the Prince of Wales saying they're pregnancy planning, we will try to expedite them. Okay. You know, admittedly, there's a waiting list, but women planning pregnancy we try to see. All right, let's have a chat about elevated BMI, because this is the flavour of the month at the moment. Everybody's on these drugs. These are, I think, actually these are my bariatric surgery references, but these are the most useful references, I think, for bariatric surgery. The Queensland clinical guidelines for obesity and pregnancy are particularly good and practical. And if you want some things that are a little bit more theoretical, these other two are pretty good. All right, so high weight in pregnancy we worry about. We know that, you know, if your BMI is above 35, you have an increased rate of congenital malformation, gestational diabetes, gestational hypertension, preeclampsia, large babies, thrombosis, maternal mortality is actually increased. I've got here just some comparisons, you know, with sleep apnea and diabetes to show that, you know, there's overlap, and sometimes women will have one or more of these conditions, and the risk is comparatively increased. Just to remind us about, this is not for pregnancy, but just losing weight in general, you don't need to lose a lot of weight to get metabolic benefit. But you do need to lose a lot of weight to get mortality benefit and cardiovascular benefit, so at least sort of 10 or 15%. And historically, that's really only been available with bariatric surgery. When you look at the drugs historically available, these ones here on the left, you know, a lot of people would get 5% weight loss, but not very many people would get 10, 15, 20% weight loss. And I'm sure you're all familiar with the side effects, particularly of phentermine and topiramate, and they're not very tolerable and usable long term. So really the semaglutide and now the tirzepatide are drugs that have suddenly made practical weight loss within reach, within tolerability of side effects. And they've got significant side effects, but they also give significant weight loss. This is tirzepatide at the 15 milligram dose, and about more than 50% will get 20% of weight loss or more. So you understand why these drugs are being used. Again, just reminding us about the physiology of it. These drugs act through the incretin effect. So if you give someone IV glucose, as compared to an oral glucose load, you get a much stronger insulin effect, insulin release in response to an oral load. And that's because of these incretin hormones that come from your gut and help you release insulin and also change your gut emptying. There's a number of incretin hormones. GLP-1 is only one of them. The tirzepatide is actually a GLP-1 and a GIP drug. And there's other drugs coming that are going to be influencing these other hormones. So it's going to become a more important area over time. GLP-1 has multiple effects in the body, from the brain through with appetite regulation, through the pancreas, the gut, also actually in the ovary and testis as well. And there's not a lot of data yet, but some suggestions that these drugs might improve fertility for women with PCOS. But that data will be improving over the next couple of years. Again, I'm sure you're familiar with this. The ones available in Australia, at the moment are liraglutide and semaglutide, and actually tirzepatide has now turned up. And approved for type 2 diabetes at the moment, liraglutide, semaglutide, dulaglutide, and then the tirzepatide. Interestingly, calls to Mother Safe have been increasing. Prof. Deb Kennedy lent me this data, just showing the dark blue is semaglutide phone calls in 2022, 2023, they've escalated, and this is from a couple of months ago, but the calls for 2024 are increasing as well, just showing how much they're being used in our community. Now, in terms of pregnancy, all of these drugs are advised to stop before pregnancy. And the time to stop them depends on the half-life of the drug. So Ozempic has a half-life of about a week. So if you think about 5 half-lives, then at least 5 weeks, and the manufacturer says 8 weeks. Liraglutide has a half-life of about 14 hours. So it could be stopped, a week or so prior to conceiving. This is just looking at animal studies, looking at exposure, and there's issues with reduced embryonic survival and then bony defects and congenital malformations related to the skeleton in these drugs. We don't have information yet on tirzepatide particularly. In human data, these drugs, the world is conducting a natural experiment because there's so many millions of women using these drugs and then conceiving on them. So in these two graphs here, we've got the Nordic countries and then the United States. You can see that over time, there hasn't been a lot of change in use of these medications in the Nordic countries. In the United States, the green here is the GLP-1 drugs, so Ozempic, etc. And you can see that really escalating over the last few years and the sulfonylurea is dropping off. And that's number of exposed pregnancies per 100,000 pregnancies. So in the United States at the moment, about 200 pregnancies per 100,000 are being exposed to these drugs, and it may well be higher than that. This is interesting. Okay. So the question is about, what about birth defects in humans? Because in animals it looks like skeletal birth defects. So this is graphs of major congenital malformation and then cardiac malformation. And here you have this is women with diabetes, okay, because remembering that women with diabetes have an increased malformation rate, you don't want to compare these drugs to women without diabetes. You want to compare it to women with diabetes. So here's women on insulin who have a congenital malformation rate of about 8%, and the GLP-1 receptors agonists are here, and it's very similar to insulin, okay? In terms of heart malformations, again, fairly similar to insulin. So an increased rate compared to the background population. But what part of that is diabetes and what part is a drug is unclear. And given that we know insulin doesn't particularly cross the placenta, and the rate of malformation in women with insulin is about 8%, and the rate in women with GLP-1s is about 8%. It doesn't seem to be a lot of excess drug effect of malformations. These pretty pictures are women who are on a GLP-1, women who had diabetes when were not on a GLP-1, and women who had a high BMI and were not on a GLP-1. And what they show in the salmon colour is pregnancy, Up here at the top, in the dashed line, is deliberate termination of pregnancy. In the blue is pregnancy loss, and in the dark pink is live birth. So you can sort of see over the course of pregnancy, everybody starts pregnant, and then some have terminations deliberately. There's a certain rate of pregnancy loss. And then, at this end of pregnancy, at 30 weeks and above, you start seeing live births coming through. So that's what that picture means. And the relatively reassuring thing here is that these patterns are the same, right? There's no major difference in the general pregnancy loss rate. There's no major difference at when they start giving birth. So these patterns between the three are very similar. Now, both this data and this data are based on a couple of hundred women, right? So in a couple of hundred women on these drugs, the data is relatively reassuring, but it's a couple of hundred women. So we still would recommend that people do not conceive on these drugs. And given that weight loss improves fertility, when they're on these drugs, they should be encouraged to have contraception if they're at risk of pregnancy. So for women generally with a BMI of above 30, I think the really important things are excellent nutrition, being fit and active, aiming to have the focus on being healthy and not necessarily the focus on a particular number. I mean, in an ideal world, they would lose weight and hold their weight at a normal level prior to conceiving. But in the real world, we know that that's biologically very difficult to do. And depending on your age and how long you're trying to, when your timing of pregnancy is, the chance of you losing significant weight in a timely fashion before conception is not high. So I tend to focus on excellent nutrition, being really fit, thinking about making sure I don't miss their diabetes, I don't miss their hypertension. Do they have sleep apnea? Do they have any of the other complications of having a high BMI? And then if they're taking the GLP-1 agents at the moment, the recommendation would be to stop them at least 8 weeks prior to conception. Questions about GLP-1s? Yep. So the question was if they come in and they're pregnant and they have been taking these medications. So first up, you stop it when you see them. Second up, you say to them, look, the research so far has been relatively reassuring, but you need more conversations around this. And they need to see they need to either come up here. You can certainly call Mother Safe and have the conversation. The data keeps changing at the moment because more information is coming through. So in a year or two, we'll know a lot more about what's going on in this space. But at the moment, I'd call Mother Safe, send them up here, we'll have a chat to them about it. At least to the obstetricians and the midwives or their private obstetrician, if they, are feeling unsure about it, they can send them on to us. But I think I'd start with Mother Safe and ask them what the new data is because it's a changing space. All right. Okay. What if she's had bariatric surgery? So this was a woman that actually gave us nightmares. She ended up really well, but it was very tricky. She came from the periphery at 28 weeks. She'd had a gastric sleeve 6 months before pregnancy. And in Australia, about 80-90% of bariatric surgery is gastric sleeves at the moment, and about 70% of them are done on women of childbearing age. So this is not an uncommon scenario. She'd had rapid weight loss before pregnancy and continuing into pregnancy. She had renal colic with stones known before pregnancy. And she came into us with edema up to her waist, really tender right up a quadrant, normal blood pressure, hypoglycemia, and spectacularly abnormal bloods. And some of these bloods are indicative of malnutrition. So she was anemic. She had a low albumin and a low pre-albumin. She had low vitamin A. Her other vitamins were not too bad. She'd been taking some supplements. Her cholesterol and stuff was quite low for pregnancy. And again, that's a marker of malnutrition. We obviously worked her up and spent a lot of time contemplating her in the multidisciplinary team. And we ended up actually giving her nutrition management. The differential when we first saw her was all of these things. And we ended up deciding she had gallstones and kidney stones and malnutrition. She got intensive feeding from the dietitians. She had ongoing renal colic and stones, but she actually delivered at 37 weeks in the peripheral hospital that she came to us from. So this is a very preventable scenario, and it's all about nutrition. So I think I've said about the HELLP is a condition of pregnancy that's similar to preeclampsia. It overlaps with preeclampsia. It's very rare. It's hemolysis and elevated liver enzymes and low platelets. It can be difficult to tell apart clinically. They'll tend to have more abnormal liver coagulopathy sometimes and less of the hypertension. But the treatment is the same as preeclampsia, which is delivery, right? So just of these differentials, just by the by, acute fatty liver, and I should have written here, of pregnancy is a specific condition that has a distinct maternal mortality rate associated with it. Preeclampsia, HELP, and then cholestasis of pregnancy. So these are all very pregnancy-specific conditions. I guess when we look at women with health conditions in pregnancy, so in this instance, abnormal liver function, we first think about what are the normal causes of abnormal liver function, right? Does she have gallstones? Does she have cholecystitis? Does she have drugs that are causing her abnormal liver function? All the usual things. And then we add the pregnancy diagnoses on top that are specific to pregnancy. And then we try to work through what it is. And you can actually apply that to everything in pregnancy. So she comes in with shortness of breath. You don't automatically think it's definitely a PE. You think, well, okay, is it asthma? Does she have a chest infection? Does she have a virus? Right? So in this instance, we worked our way through these things and thought about them. We did imaging and bloods and things and ended up working out that this was what was going on. I've got internal hernia here in brackets because bariatric surgery, and it tends to be the malabsorptive, the Roux-en-Y or the complicated bariatric surgeries, can get these hernias inside in the scarring left over, and the loops of bowel can sort of loop in on themselves. It's really hard to diagnose and has a high mortality rate associated with it. Sometimes it gets diagnosed just at laparoscopy. So it's something to keep in the back of your mind whenever you see someone with bariatric surgery with acute abdominal pain. I've mentioned this already about the rates of surgery. So the questions with bariatric surgery are really around when are they supposed to get pregnant after the surgery, what are the pregnancy outcomes like, and then what to do. So in terms of getting pregnant, the recommendation is at least a year. And that's based on a number of cohort studies. It's largely from women with Roux-en-Ys, the international literature. We just looked at the data in the Queensland, which has most of the bariatric surgery in Australia. And actually the timing didn't seem to make too much difference there. So I suspect it's more a nutrition thing, that losing weight rapidly at the time of conception usually comes with being in a state of malnutrition or poor nutrition. In terms of pregnancy outcomes, this is a systematic review, and they've taken women in two groups. So the blue group is matched for their pre-surgery BMI. So if their weight was up here and then they've now had surgery, they're comparing them back to women of their old weight. And then the red group is matched for their weight now as they enter pregnancy. So two different comparisons, both important, because you want to know, has losing weight improved things? And secondly, has the surgery added risk at the same weight? So two different questions. So if you look at the blue, so has losing weight improved things? Yeah, it has. You can see less gestational diabetes, less hypertension, less preeclampsia. You can see less big babies. Sounds really good, but also more small babies. And if you take the women of the same weight, they've got the same rates of gestational diabetes and hypertension. So you've reduced their risk of those things. You get less big babies, but you also get less small babies. So what this is saying is that by losing weight, you've improved some pregnancy outcomes, but you've added a risk of small babies. So these are women who get increased monitoring for fetal size on the way through pregnancy. And again, it comes down to good nutrition. So before bariatric surgery, people often have poor diet quality and deficiencies. A lot of them have spent a lot of time dieting intensively. And this is not pregnant women, but there are high percentages of nutrient deficiencies in both the malabsorptive, so like the Roux-en-Y surgeries, and also the restrictive, the gastric sleeves. Okay, so they're more deficient than you think they should be in the fat-soluble vitamins, because you don't think a sleeve would affect it. But when you've got a sleeve, often your diet's not great, so you end up being malnourished in those micronutrients. And we know it matters because birth defects go up with bariatric surgery a little bit, but when you adjust it for supplementation of folic acid in this case, the birth defects drop back to the normal rate. So these are the suggested guidelines, and I would look at the Queensland. If you Google, Queensland obesity guidelines, they've got really good tables in there of the micronutrients and what, when to measure it during pregnancy and what levels and things you're looking for. Vitamin A, don't forget, you've got to avoid the retinol form. This is a group you can see night blindness on occasionally during pregnancy. So measuring their vitamin A is important. What about gestational diabetes? Because that's a question we get asked all the time. If you give women with bariatric surgery a glucose tolerance test, about half of them or 60% of them will have hypoglycemia during the test. And about 60% of that's at the 3-hour mark. That's when they're in the car on the way home, right? So we don't like doing glucose tolerance tests in people with bariatric surgery. Those who have hypoglycemia in a glucose tolerance test will have a shorter time since surgery, mostly the more complex surgeries, less rate of GDM and higher rate of small for gestational age. Over here on the right, I've got the different surgeries. So the blue is gastric band, the red is sleeve, and the green is Roux-en-Y surgery. And you can see here at the 2 and 3 hour mark, both the sleeve and the Roux-en-Y drop their glucose down. The band doesn't as much. So we don't do oral glucose tolerance tests in women who've had bariatric surgery. How do you screen for it then? Before pregnancy, you check they don't have overt diabetes. In the first trimester, you do a fasting sugar and HbA1c again. And these are the cutoffs that are currently being suggested for diagnosing early gestational diabetes with an HbA1c. At the 24 to 28 week mark, you can look at a fasting sugar. The HbA1c won't be as useful because it will have dropped with the increased red cell turnover of pregnancy. And then we tend to do at the moment a week of capillary glucose monitoring. There's lots of work going on in the space of using a CGM and putting that on, but we don't have cutoffs and numbers for that yet. I'm happy to look at it and work out if I think someone has GDM, but this is what gets used at the moment. So I think for bariatric surgery, what I would say is it's all about nutrition. They need ongoing dietitian support, and particularly leading into pregnancy and in pregnancy. And then when they're pregnant, we'd really like to see them, have them sent up to the dietitian here if they don't have one. And then we would like to see the bariatric surgery women when they're pregnant. Questions? Yep. So the question was around dosing of folic acid with bariatric surgery if their weight was back to normal. I would still give them the higher dose myself of at least 2.5 milligrams, if not the 5. We usually say 3 months before pregnancy and then continue it through to about 12 weeks or so. But then they might need, just for their own nutritional supplementation, some ongoing supplementation. So what we generally do, certainly with the Roux-en-Ys, is 2 adult multivitamins, checking the form of vitamin A in it, because you've got to avoid that retinol form. In the sleeves, I tend to use 1, but then monitor them because they don't tend to be quite as deficient as the Roux-en-Ys do. But they really need the nutritional support.
After 3 weeks, after 3 months,
Yep. Yeah, they're not. So in the pregnancy, and correct me if I'm wrong, we usually drop the folic acid down at about 12 weeks to just regular supplementation. But the bariatric surgery women might need ongoing supplementation. So the question was about if the BMI was 26, 27, would we still do 5 milligrams? In someone with bariatric surgery, I would. Yep. Other questions? So I think I know we've gone through lots of different topics. They're sort of related to each other. So pre-gestational diabetes, we really would like to see them preconception. There's lots of drugs you need to stop prior to pregnancy or at conception. But that HbA1c and checking them for complications is really important to pregnancy preparation. And then once they're pregnant, we would try to see them within a week up at the hospital. Women with high BMIs on the GLP-1s, it's all about nutrition and exercise and being fit and healthy and screening them for associated conditions and then stopping it. At the moment, advice is at least 8 weeks prior to conception. And bariatric surgery, again, about nutrition. So, okay. Any other questions? For the women with bariatric surgery? Yep. So the question is around calcium and vitamin D. Most of them will need calcium supplementation. If their BMI is still higher, they'll probably need calcium supplementation for preeclampsia risk reduction. So I do 600 milligrams twice a day in the pregnancy from that point of view. The vitamin D, I tend to monitor the level and not supplement. See the level, everyone argues about vitamin D. To me, they need a vitamin D of at least 50 and preferably 70. Now, people have big arguments about where the vitamin D level should sit, but that's what I use. So, other questions?
Thank you for that, Dr. Barrett. Quick announcements. Well, not announcements, but just some follow-up from things that have happened at the hospital. So a reminder that yellow cards need to be filled out at every single appointment. There's yellow cards that are coming into the hospital and they haven't been updated with recent bloods or scans. So if you can make sure that you do that, or if the woman doesn't bring her card in, which often happens, if you can print out things for the woman to take into her next appointment with the midwife. And then also there's been a lot of referrals. So the HealthLink e-referrals, which is great. And I know everyone wants to get into the MGP and they want the referral to come in really early, but then a lot of referrals are coming in without any of the bloods or urine or ultrasound. It's still at a time when those women may miscarry, and so they're getting allocated appointments and then they're not coming to appointments. So it's actually causing a bit of a problem. So if you can try and hold people off and send the referrals with those initial bloods and ultrasound after, so a bit more around 8 weeks or after, would be much better. Thank you.
There used to be once upon a time a very lovely little pamphlet for antenatal shade care, etc. Does it still exist?
So this was a question about the antenatal shade care pamphlet, and there's one in the that you can print online, and it's got a list of all the antenatal appointments with the GP and at the hospital. So there is that, but the schedule's going to change soon, so there's going to be a new one coming out soon next year. We can maybe put it on the chat or email it to you where you can find it. Yeah. Yes, so that's a useful thing that you can hand out to women. So I'd like to introduce our third speaker, Katy Hunt, who is going to talk to us about lactation and breastfeeding problems in the first 6 weeks, which is a really relevant topic for GPs. She's a clinical midwifery consultant and international board certified lactation consultant for the Royal Hospital for Women. Katy's adamant that she's a midwife first and foremost and has been working on the postnatal ward since 2001. She's cared for and supported new mothers with their breastfeeding goals since 2008, as well as first-hand experience with her own 2 boys. Katy presents weekly breastfeeding classes to pregnant women and new parents and can be found either talking, teaching or observing breastfeeding to women and staff Please welcome Katy.
Thank you. I would like to acknowledge and pay my respect to the people of the Eora Nation and to Aboriginal people of whose land we gather, and I pay my respect to Aboriginal elders and Aboriginal people here today. Within this presentation, we will use the term woman. This is not to exclude those who give birth and do not identify as female, and the preferred language and terminology is described and guided by each individual person we care for. So the objectives. Counsel a pregnant woman or mother with concerns about her ability to breastfeed. I know you asked for 6 weeks, but I thought I might use this opportunity to orientate you to the antenatal education and counselling we at the RHW provide using a case study, and we often encounter mothers who experience breastfeeding challenges with their first child. I'll describe how to refer to the antenatal lactation clinic and explain the basics of breastfeeding, just a little refresher, and troubleshoot common breastfeeding concerns in the first 6 weeks and refer a mother and baby experiencing breastfeeding and lactation issues. So, what does BFHI stand for? I have to remind you all. Does it stand for Breastfeeding for Health Initiative, Breastfeeding Friendly Hospital Initiative, Baby Feeding in Healthcare Initiative, or Baby Friendly Health Initiative? It's D. I just want to illustrate that it's not breastfeeding hospital. So we look after all mothers, whether they want to breastfeed or not. I'll just skip that one. The 10-step successful breastfeeding is how we get accredited, and when we meet all those 10 steps is how we pass. But one thing I do want to tell you is that we are very privileged at the Royal, and we are one of the only districts, Southeastern Local Health Districts, that are all BFHI accredited facilities. In addition, the Child and Family Health Services that we are affiliated with are also BFHI. So you're probably very familiar with referring patients to child and family health nurses and the excellent care that they carry on with and look after their mothers and babies. And the Southeastern Local Health District works very closely with the hospital and the child and family health nurses. So breastfeeding advice comes from everywhere. And there's an endless array of devices, experts, videos, and influencers providing that information. When I had my babies, it was 2 books, What to Expect When You're a Breastfeed, What to Expect When You're Expecting, and Baby Love. And now our patients have instant, they have Instagram, they have TikTok, they have everything, and we have to help them filter that. Would you agree? So, counsel a pregnant woman or mother with concerns about her ability to breastfeed. What do you say? Does anybody want to offer the opening question or the opening line?
How do you feel about breastfeeding?
How do you feel about breastfeeding? That's a good way to start. That's polite. Why don't you go for, how long are you going to breastfeed for? 97% of our patients initiate breastfeeding, and of the ones that don't initiate breastfeeding, we usually know there's some significant medical issues, or they may have some very fierce ambivalence about breastfeeding, and it's okay to take a step back and go, oh, it sounds like you've made up your mind. Can I answer any questions about formula feeding or formula preparation? I think would be a good way to go. But anyway, it sounds like you're doing what's best for the family. So, your influence and reassurance is very welcome when you ask about breastfeeding, and your influence makes an impact. And so given in a position of trust and credibility, when you say, how do you feel about breastfeeding? How long are you going to breastfeed for? It really carries weight. When you counsel someone about breastfeeding, they might say, I had a terrible time last time. They might have concerns and misgivings about breastfeeding. And I haven't got them all, but I've highlighted a few major ones there that might impact breastfeeding. You may need to counsel someone. So breast hyperplasia can be the underlying reason for breast augmentation. I don't know if you know that. And breast augmentation isn't something to think about lightly. When I counsel mothers who've had breast augmentation, they're not all done the same. Sometimes there's a lift. Sometimes they have periareolar incisions. Sometimes they have inframammary incisions. And sometimes are weird and wonderful ways of augmenting breasts. So that's a really important one to consider as well in counselling a pregnant woman about breastfeeding. Do you feel like you can ask them about their appearance of their breasts or breast changes? Yes, no, sometimes. I think that's a good place to start. Have you noticed breast changes? Have you noticed that they've gotten bigger or darker? Those kind of things. That can invite a question. Oh, actually, my nipples are inverted. Is this normal? Okay, so let's do a case study, which might help illustrate what we're talking about there. CM is 28 weeks pregnant with her second child with a history of breast implants. I wonder what the statistics are in this hospital. Her first child was born via caesarean section in 2021, and she states she didn't have a lot of support in lockdown. She experienced nipple damage and pain and used nipple shields. She expressed her milk and supplemented her baby with formula and says she was very distressed and may have developed postnatal depression. She never felt like she had enough milk. Her notes indicate that she was assisted by our lactation services at the Royal. She followed up with midwifery support program. I put hospital in the home, which is a similar thing. And the child and family health supported with contact via breastfeeding clinics. And she also engaged the Australian Breastfeeding Association. So it sounds like she got a lot of support when I went through her notes. I just want to illustrate that sometimes mothers will get a lot of support and they will still feel like they didn't do a good job. The lactation services at the Royal Hospital for Women can be really helpful antenatally. I offer an antenatal clinic on the first and third Wednesdays. I also do an antenatal breastfeeding class. I put those in the slides, which you can refer to later if you want. But those appointments can really help with having those conversations. So let's get on to what CM told me. So I gave her a phone call at 30 weeks and I met again at 37 weeks. Her debrief and recount of the birth events and challenges as she saw them. And she actually blamed herself, even though she said, I didn't get enough support. Most mothers do blame themselves and their narrative is very much about struggle and it was hard work. It can be therapeutic to say, that must have been really hard. So breastfeeding basics. So trying to figure out what happened to this lady, how we can help, how we can avoid future problems. Remember, babies are born with an innate feeding cues and they typically self-attach and breastfeed within 1 hour of birth. Was there any separation at the birth? Was there any reason for the separation? Was the baby early or was there a caesarean that was complicated? The more time apart, the more interference with norms and opportunity to establish breastfeeding. I know if you find these helpful, I've attached some links to these too. It might be helpful if mothers are struggling or forgotten where the resources are. TikTok and YouTube actually have like limitations on showing a bare breast or showing a nipple. So they won't see videos this good without knowing where to look. And the ones that you will find in a Google search engine are, of course, sponsored by Lancino, Medela, Amida. And their job's to sell breast pumps, right? So the Global Health Media one, Breastfeeding from New South Wales Health, Good Things Take Time, are useful breastfeeding videos. Just another recap. Most mothers don't have any milk right away. Is that true? They have something better. They have colostrum. Very valuable. It's low milk supply day 1 or 2. It's just not a thing, we like to say. This is how we find, we sometimes find this a bit challenging. Sometimes babies are born with low BSLs and will start comps before, but I actually need to audit this in a hospital and our breastfeeding rates are considered not exclusive when babies have a comp within the first 2 days at hospital. So these comps can really undermine mothers' confidence. When do you think this happens? Rapid onset milk productions. This nearly always happens when mothers have discharged and are at home. And I get a lot of phone calls. I think I've got mastitis. And would you say you have any of those calls before? I think I've got mastitis. And often it's just that rapid onset milk production where things are starting to unravel, nipples are really sore, and it's not giving women the relief that they've been waiting for. It's a mess. What do you do? Breasts are painful. Sometimes there's no milk flow and latch suddenly becomes impossible and nipple damage starts to appear. Some of my tips. Hand express, lying flat on your back until the breasts are softened. When milk flows or spurts, sit up and breastfeed. No hot showers, cool compresses, do not massage, maybe a supportive bra. What if there's delayed onset lactogenesis too? I've listed some of the reasons that might happen: poor feeding, high BMI, PPH, retained products of conception, sepsis, pain, breast surgery. There's probably more. But timely, appropriate supplements can minimise the stress of having baby lose too much weight. But at the same time, supplements can undermine a woman's confidence, right? So we've got to get the balance right. Here's a case study. DB, family sent to the GP for weight and follow-up, unable to get home visits and first child and family appointment for another 9 days. Mother is exclusively breastfeeding. It's a day 4 baby born via caesarean section at 37 weeks. He is unsettled and is jaundiced. Birth weight was 2.9 and weight loss is approximately 11%. Baby has wet and dirty nappies, but there are urates noted. Mother is tearful and reports nipples are cracked and bleeding. What do you do? Sorry. We often hear the foundation to successful breastfeeding is getting the right latch. A red flag is damaged nipples. Look no further for issues if the nipples are broken. Damaged nipples mean the baby is not sucking correctly, not removing the milk, resulting in low supply and damaged nipples. Act on nipple damage. Nipple creams and expensive silverettes are useless if the baby's not sucking correctly. The other thing in this situation would have been the weight loss. The other thing would have been small baby, probably wasn't suckling all that well. There was definitely a delay in milk production, establishing feeding. So just a quick breastfeeding check. Is the baby feeding 8 to 12 times a day? Yes, we've got an alert, well baby. 4 to 6 pale soaked nappies and 4 to 6 soft runny stools. Parents will say, yes, my baby's done a wee, but is it heavy? Is this baby wet? Is this baby hydrated? Breast can be full and uncomfortable first thing in the morning and feel soft and empty in the evening, most of the time. And nipples are tender but intact. So, DB, our main concerns were weight loss, agree, 11% is a bit too much, and jaundice, and nipple damage. The breastfeeding, I suspect is poor milk transfer and probably related to the late preterm, the jaundice, and the poor latch. The action, supplement promptly. Plan to improve the latch and establish direct breastfeeding. First, supplement. Second, address the latch. I can't do much with damaged nipples and a tired baby. Okay. So I would need to have a conversation about infant formula, right? We have to do this. I offered to you that the raisingchildren.net has an excellent video on preparing infant formula, free from coercion, from formula companies and all that kind of thing. This could be a long conversation, but thankfully there's heaps of this stuff on the internet. This one's Raising Children, and it's a short term to supplementing the baby. My action, triple feeding, not yet. Does everyone know what triple feeding is? Breastfeed, top up, express. It's exhausting. So expressing will preserve lactation until direct breastfeeding can be addressed and managed. Expressing will rest or damage nipples, will require a breast pump. Does everyone feel comfortable about telling them which breast pump to get? Your options are Australian Breastfeeding Association, hire them. MediRent, hire them. MediRent, I think I call My Breast Pump now. Purchasing from Amazon. Do it manually. That would be great. It is hard for some women. Yeah, some women get really bothered by that and they go, what do I do with these things, my hands? But they do work very well, I would agree. But when you've got a quick 15 minutes to sort it out and they've got a breast pump, do whatever you can and feed the baby. But honestly, this will decimate a mother's confidence when her baby, she has to watch her baby take a supplement with a bottle and tea. Okay. What about a nipple shield? I would say not yet. When the baby's weight is more reassuring and milk volume's increasing, baby's sucking is stronger, I would say a nipple shield, sorry about the typo there. I would say a nipple shield would be very useful. It's used for late preterm babies, and Medela is the one we used to have in hospital, but they're very accessible. I would just put that out there because some of the inferior nipple shields don't fit them properly. They're too small, they're too narrow. So the Medela Amida ones are actually preferred. Breast pumps indication would be resting, expressing, a premature sick baby, and supplements when supplements are indicated. Of course, we would give available breast milk first. So, as I said, ABA rent them, Medi-Rent, many are available on Amazon. Kmart has one for $60 and Medela has one for $500. So, hospital grade recommended for prems. So if we can help at this stage, it could be a while for the baby, a mother and baby to get to the child and family help. We're available up until 3 weeks. The other resources they'll find on the baby's blue book, there's fact sheets in there, there's lots of contact numbers, Caritani, Tricillian, and hopefully in the blue book will be that invaluable contact number for the local child and family health services. So even if they can't get in straight away, they can make contact, they can get phone calls. So the New South Wales Personal Health Record Book has these contact details and also private LCs if that's within their resources. So there's a list there that's for your use. Don't forget MotherSafe medications in pregnancy and lactation services. Have you ever used them? They're extremely useful with mothers needing to take medication during breastfeeding. I was called this week over to ICU to support a mother who was needing to establish lactation while she was unconscious. So let's get back to the case study. So DB went to the child and family health appointment and she returned to you at 12 days postpartum requesting domperidone. Does that happen often? The mother is using a nipple shield and is topping up baby with 60 mils PC, which means after feeds, 8 times a day, and she's expressing about 20 to 40 mils at any given time. She's been put on a feeding plan, this triple feeding plan. So, low milk supply or galactagogues domperidone. The therapeutic guidelines has a very useful 10 milligrams to start with 3 times a day, and you can increase it to 20 milligrams 3 times a day. The evidence that it does help is useful. It's probably about a 40% increase in the general population, and some ladies experience even more. And it works best with a triple feeding plan or added stimulation milk removal. So it doesn't work on its own. Even LactMed offer domperidone as a complement to good breastfeeding support and advice. That's what their statement is, LactMed. It's useful with good breastfeeding support and advice. So therapeutic guidelines, just to the QTC interval, if you didn't know this, it says this is a cut and paste. Domperidone can increase the QTC interval, but there is no evidence to support routine electrocardiograph monitoring before use. The absolute risk of ventricular arrhythmias in young, healthy individuals without risk factors is likely to be very low. Okay, so I've written that up there, domperidone 10 milligrams orally. So the data available suggests that it's okay in breast milk, and they probably receive less than 0.1% of the maternal weight adjusted dose. So very helpful in breastfeeding. Let's do another case study, because this is one of your common questions. Is probably mastitis, one of your probably your common issues. I know it's a gross photo. It's not the patient, don't worry. So she's 3 weeks postpartum and she's come in with red, painful right breast, temperature 37.9, and says baby's refusing the breast, so she is pumping. Right. Obviously, lactational mastitis. Inflammation can progress to bacterial infection rapidly. It's painful. Milk flow can slow, exacerbating pressure and pain in the breast. Breast refusal. The reason they refuse the breast, sometimes the taste can be different, and sometimes milk flow is reduced. The inflammation causes the narrowing of the ducts and the flow is just too slow and the baby will refuse the breast. It's a symptom of mastitis. And mothers will start to say things like, I couldn't drain the breast, so I got the pump and tried to pump it out and nothing was coming. And they have this incorrect notion that they need to drain the breast. So we're very careful on the language that we use on this. So the symptoms, that's not right. Analgesia, anti-inflammatories, 4 symptoms provide analgesia, anti-inflammatories, cool compresses, rest, feed to infant cues. If the baby refuses the breast, it refuses the breast. Offer the other side. It may need a supplement till it's reached satiety. It may need that, that breast needs to downregulate. Antibiotics. So our policy says flucloxacillin, if they're not allergic to it, 500 milligrams orally, 6 hourly. Many authorities recommend 10-day course to minimise recurrence. So the Academy of Breastfeeding Medicine protocol has been revised and the RHW updated their policy. Oh, guys, honestly, it came out 1 month after I finished my policy, so I had to call it back and do it again in 2022. So the case study. I phone called to JT after the weekend. The baby's still breastfeeding and she feels much better. No temperature and baby feeding from the affected breast. Reports the lumps are still felt. And she's not pumping unless the baby's not latching. So she may still feel the lumps. And we explain to the patient that mastitis is not like a lump that needs to be rolled out. It doesn't need to be pushed out or squeezed out. It's that the lump is like cellulitis. You wouldn't massage cellulitis, right? So we downregulate. So if a mother is less than, so what if your mother needs to be admitted? I just want to go through the pathways for you. This might be helpful. What if the mother is very unwell? I had a phone call this week for a mother who had a confirmed abscess. So if the mother is less than 3 weeks postpartum, she may present to birthing unit for triage. So less than 3 weeks, they can come back to the Royal and be triaged. If she's more than 3 weeks postpartum, she needs to present to ED, Prince of Wales ED, because it needs to be ruled out for an abscess. So if you want to or can arrange an ultrasound through RHW Breast Centre Mondays, Wednesdays and Fridays, that's the number there. And that might be helpful. If an abscess is confirmed, then a breast surgeon will manage. So that's helpful. A phlegm is, I would never use that word because it would be out of my scope of practice. It would be confirmed on an ultrasound. But fluid collection in the presence of inflammation and deep tissue massage can propagate phlegm formation, worsening edema and cause microvascular injury. That's why we don't touch them. We don't massage the breast. Abscess, so lactational abscess progression from bacterial mastitis, and 3 to 11% of women with acute mastitis will develop palpable fluid collection. Initial systemic symptoms and diagnosis can be from clinical examination, history and ultrasounds. So recurrent guided ultrasound aspiration seems to be how we manage it here, and it can need repeating. It's a very awful ongoing problem for the mothers. Can they still breastfeed? Yes. Can they develop a fistula? Yes. The galactocele is something a bit bigger. They can have this large collection and it's usually bigger than an abscess. It's usually a lot bigger and it can recur with subsequent pregnancies. It's usually, the ABM advise that they're less painful as they are less systemic symptoms usually is that it becomes infected. So here's another GP issue you might encounter: inverted nipples. I touched on that before. You may identify them antenatally or you may identify them later. I wouldn't discourage breastfeeding, just present them with a plan that includes early hand expressing. So nipple shields can be useful, and some mothers' nipples protract with stimulation and do not. Some mothers protract and some do not. Devices to pull out inverted nipples, I wouldn't encourage them. Breast pumps can kind of do that. So oversupply, how do you know it's oversupply? Babies are often unsettled and very unhappy. Mothers complain of full, uncomfortable breasts. Babies have excessive weight gain or greater than 300 grams a week and may have green frothy stool, nappy rash and colicky symptoms. Everybody's miserable when there's oversupply. So the reason I put the cabbage there, it's a personal joke here, I will not take it off my policy. I refuse to take it off my policy. If someone takes the time to read my policy and spots the cabbage in there, that's great. That's awesome. So cabbage is thought to have anti-inflammatory properties, and it's a lovely complement to the work that you already do, which is cool compresses, rest, analgesia, and antibiotics if that's necessary, but not usually in oversupply. Mothers with oversupply can often represent with mastitis symptoms. Okay, I thought you might like some information on tongue ties and how we do that here. So tongue ties are a menace, aren't they? Damaged nipples, visible restriction, poor weight gain, feeds take a long time. The RHW neonatologist releases the frenulum, frenotomy, here as an outpatient. We do that, we see patients, we don't see them after 3 weeks, they're getting a bit big then, but within the first 3 weeks, we can see them, and you can use the contact numbers I already gave you. They have had, they've had a Hazel-Baker assessment, which is an assessment of the baby's lift and extension. And the reason we're doing this is we're trying to build a case for a clinical diagnosis of a tongue tie and when it's appropriate and when we cut it and whether it made any impact. We've got about 280 babies that have been in our data, and we can see that we're doing a good job. It's a real timely opportunity to cut the tongue. It's a real timely opportunity to not have the breastfeeding interfered with for too long, and we're seeing some good data on this. And it's a Medicare for patients. They can come back as it's a day admission, mother and the baby. So I don't know if that's helpful for your Medicare ineligible patients. Then there is a cost if they are not Medicare. More feeding issues, may need to refer to a private clinic if tongue tie is noted later after 3 weeks. There are a few around. Google will give you a few of them. And Sydney Children's Hospital feeding clinic may be used if there are more significant sucking feeding issues, example laryngomalacia or undiagnosed cleft. We don't see patients after 3 weeks for promoting, but the LC can support mother and baby for unresolved feeding issues until the Child and Family Health Review or the mother requests it. Okay. So the antenatal expressing, I don't know if anybody's comfortable with that or if your patients are asking about that, but our patients are just obsessed with it. And I just want to make sure that they have the right information so that they don't go gung-ho with this. The DAME study reported that the risks and benefits were there, and that it wasn't about, there wasn't a danger if they started around 36 weeks. In the cohort, it didn't show less babies admitted for sugar drops in clear cells. It didn't show that more babies avoided admissions to the NICU. It didn't show that. But it did show that the mothers had better breastfeeding outcomes and they loved it. And there was a small collection of mums that reported they got more anxious because they couldn't get anything out. So it was an enormous benefit to doing this. And some hospitals actually have policies on this. So around 36 weeks, our midwives can feel comfortable offering this to mothers. They don't have to do it. And I also say it's not about stockpiling. It's about practicing the art and skill of hand expressing before they give birth. So that's the advantage of it. They bring in their little frozen syringes when they come in. Okay, here's some more useful resources for you. Child and Family Health, Private Lactation Consultants, Tracilian, Karatani Care Line, Mother Safe, and the new parent line is 1300 1300 52 from, I think, from 8 o'clock to 11 o'clock at night. There's a Child and Family Health nurse that will answer their calls in business hours. So that's good to know as well. You got that? And the Australian Breastfeeding Association, 1800 686 268. I'm sure you're all aware, but I just wanted to just give you a little recap of all the things that they provide. Amazing comprehensive website, breastfeeding.asn, introductory membership for a year for new parents. Did you know that? It used to be a cost of about $70 membership for a year, but there's an introductory membership now, which is really nice. So they have parent education classes you saw before that I do antenatal education classes, but the ABA also does them, but they're not free. I'm free. Medicare. Face-to-face counselling via very active local groups in Randwick and Bondi. You can access their schedules and their meeting points on the website. They have breast pump hire. I believe it costs about $50 a month and $25 a month for membership. And you also get the counsellor to help you navigate that and answer your questions in face-to-face contact with a human. So how breastfeeding works, you saw them outside. New South Wales Health has assumed responsibility for printing those. They're updated with the most up-to-date information that's current with the the Academy of Breastfeeding Medicine updates on mastitis. So that booklet is very well up to date, and it's a free resource for mothers. The book also has translations in 15 languages, and you can access them via the website. They're in a digital copy because they can print them. I can order them, but they like them in a digital copy because they're updated and they're in real time. So they also have fact sheets, book reviews, research summaries for professionals as well. A professional membership's about $199 a year, and you can go to their conferences. The question was, have I encountered upper lip ties and posterior tongue ties, and would I comment on that? In talking about evidence, and there isn't a lot on lip ties and tongue ties, and I wouldn't refer, or I wouldn't manage one. I would refer on if a patient suspected the baby had a lip tie or a posterior tongue tie. And again, I hope that was helpful, the perspective of 3 weeks and how we manage that. And I would refer on to the private clinics to manage those. So the question was talking about the clinics at the Royal. The clinics that I have is the antenatal breastfeeding or the antenatal lactation clinic. You can access that by calling the outpatient department and ask for an appointment in the clinic. And it's on the first and third Wednesday of the month. And I encourage mothers with breast implants or a previous challenge or either significant issues. I saw a lady with mastectomy on one side, and we counselled her and got her ready for breastfeeding. I also have the breastfeeding support unit, which is, I'll put that picture back up there. Where is she? Might as well see the people. So the breastfeeding support unit works with women when they're an inpatient, and they can come and have one-to-one support with the lactation consultant. And sometimes we work as a buffer between that delay of the discharge and the first contact with the child and family health. And so that can be an excellent opportunity to catch someone in case they have a long delay. I don't know if you're finding, but anybody that fits the northern sector of the southeastern local health, the northern sector of the child and family health, they get picked up quite quickly. We haven't even finished seeing them, and then the child and family health contact them. But anyone that's in the central area, there's an overlap, right? People that living in the Zetland area will fall in the central health area, and they might wait a little bit longer. And sometimes that's a bit too long. Those breastfeeding opportunities are missed, or those opportunities to solve problems are missed, and so we can help out with that. So the referrals are via the midwives or directly. The women can contact me directly. That's why I put that number there.
There's a question online that a lot of women who are using manual breast pumps find it hard to get a letdown reflex. Do you have any tips to help with that?
That's a good question. The manual breast pumps, like any breast pump, doesn't stimulate like the baby, and often there's an urgency or a need to hit that particular volume, and so the angst and worry. And I guess my suggestion would be gentle massage before you initiate milk flow. And again, that age-old, use your hands to initiate milk flow, get a more insight into the beautiful anatomy of the breast, and contact with where you put the pump. Sometimes it's just not positioned correctly. There's just a lot of investment in these pumps, and it's quite frustrating. You really wouldn't. I'm often counselling women who are using breast pumps, how to get off them. How do I not use this thing? And some women will come back to me and go, I don't want to use a breast pump again. I'm really triggered by the sound of that awful thing. So was that helpful?
Area, it doesn't actually help
No, no.
I've got one more question online. If people can breastfeed with implants, do you ever see problems for those who have had a breast reduction?
I definitely see problems with breast reduction. In the research, women with breast implants are more represented with mastitis, nipple damage, and early stopping. So the research doesn't specify whether women are exclusively breastfeeding or there's any breastfeeding. And the definition of breastfeeding is very vague. Was there pumping? Is there expressing? I mean, we breastfed for a minute and we breastfed for 6 months. So in the real data, we've seen that women with breast implants aren't breastfeeding for as long as women who don't have them. So they are affecting, and we don't know whether that's because they have an underlying breast hyperplasia. But the breast reduction is much more affected. And given that people could have had a breast implant 20 years ago, breast reduction 20 years ago, or they could have had a breast reduction only about 5 or 6 years ago. And we're seeing that the techniques are a little bit better in the more recent breast reductions because they're keeping that parenchymal column nipple areola complex. They're keeping that intact, and we're seeing a little bit more volume. But it's actually not the norm that you can exclusively breastfeed after a breast reduction. I would absolutely encourage someone to breastfeed after a breast reduction, but I would be preparing them for a mixed feeding journey and how best to support that.
Online, can breast milk be frozen and defrosted and heated and given?
That's an excellent question. So our just as all you came today, there's a display out the front of the hospital. It's actually premature day. I don't know if it's prematurity week or prematurity day. And our mothers provide their own breast milk for their very premature babies. And so there's a lot of information on expressing and storing breast milk and freezing it for up to 6 months. As long as it's expressed and into the fridge within 2 hours, it's good for 3 days. If it's expressed and put in the fridge within 2 hours, you can freeze it for 3 months and a deep freeze 6 months. Breast milk, when you take it out of the breast, if you don't need to, it does change the profile of the breast milk. We don't know whether the immune benefits translate when you take it out of the breast. So for all those pumping crazies in the US that love pumping, they should probably know that. But each to their own. We meet these mothers where they're at, right? So, yeah. Any other questions? Yes. The question was what my advice would be for a woman who has to stop breastfeeding. And we have an excellent fact sheet on the Royal Hospital for Women website, the South Eastern Local Health District one, on weaning or suppression. And gradual weaning is advised, and more so for women who've been breastfeeding for a longer period of time. The reason for that is they can become full and uncomfortable and maybe even cause mastitis. So gradual weaning is recommended. And also the unpacking of the feelings of withdrawing breastfeeding can be emotional. The Australian Breastfeeding Association provide excellent resources around that. And it's nothing nicer than a counsellor on the other end of the phone. Why do you need to wean? Is it as a reason that you can't help, or is it your choice? How old is the child? And also importantly is if the child was exclusively breastfeeding, how are we going to feed that child now? And do you have the resources to manage that? So, yeah, did that answer your question? Yeah, the question was, what if you have to suddenly stop for a reason, maybe resume some medication that's very important, or upcoming, like I've had women who've had to have chemo. That's very distressing. So if we know in advance, we can do it gradually. And the more that when you leave milk in the breast, the downregulation will happen. So reassuring that mum, you will be full and uncomfortable for a few days. You can try cool compresses, cabbage, analgesia, that sort of thing. And if you really want to, there's a therapeutic guidelines has your Dostonex prescription in there, cabergoline, is that how you say it? Cabergoline. And you can use that if you really need to, as long as you don't continue to express or remove the milk. That you can prescribe that for someone who chooses to suppress lactation from birth. but it's not something we do unless the doctors prefer it here. It's not written into our day-to-day, except for mothers with pregnancy loss who choose to take the Dostinex. Does that answer your question? Oh, that's something that the neonatologist and I have used to identify in agreement the lift of the tongue, the extension of the tongue, the movement of the tongue, because it's all very ambiguous, isn't it? So tongue tie can be very subjective, and it can be like, just because you can see the lingual frenulum doesn't mean you should cut it, right? And so looking at the lift, so where they get that heart shape, though one in the picture was glaringly obvious, that was a very restricted tongue. So it's helping us establish some kind of system before and argument for cutting them, just making a protocol.
Okay. Katy, I've got 2 more online questions. Do you find in your experience some foods the mother eats causes crying, colic, reflux, for example, chocolate, orange juice? How real is this?
That's a great question. You know the question. So what they eat, well, we're taught to say that the more variety the mother has, the better it is for the baby, her nutrition and her well-being. And that's kind of trial and error, what foods make a baby uncomfortable, gassy, and things like that. Some presentations by Dr. Robin Thompson, the lady that's doing a lot of work on, she sells a breastfeeding video and lots of information. Often I'm asked, what are my thoughts on Robin Thompson's stuff? And she points out that sometimes when they take a supplement, because the supplements taste so terrible, the baby can actually taste them and will refuse the breast. They'll actually taste like the fish oil in the breast milk. So if it makes the mother sick or gassy, it's going to make the baby sick or gassy. So, yeah.
This one might be a little bit related, maybe. Some advice regarding sudden breast refusal if there's not been any change in topical things.
I thought about putting that one in. Breast refusal, very distressing for the mother and the baby. And the mother's thinking, oh, what do I do? Or this baby won't feed. And that can be tough. I would call the Australian Breastfeeding Association in the early hours of the morning or whenever and talk to a human to sort of navigate through that. Because there's a sudden breastfeeding strike can make mum really distressed. Her breast will become full and uncomfortable. The baby will arch its back and carry on. And sometimes just separating them, calming down and coming back to it, that gentle baby-led feeding positions that we're taught now, we know, taking into account the baby's cues and following the baby's needs, laid-back breastfeeding. One of the things I learned when I was doing the LC was have a bath with the baby, jump in the bath, and because that relaxes the mother and the baby and can sometimes help resume a breastfeeding strike.
How long do they strike for? They must get hungry.
It depends. They're usually quite smart and go, well, I'm really hungry now, so let's get the show on the road. But some reasons for the strike could be, mother ate some food that's not very nice, or even the early days when the breasts become very full and uncomfortable, the baby will go, that's not my breast. I don't know what to do with that. So the ABA Council can ascertain, is it day 5? Maybe a little bit of hand expressing to soften the breast before the baby gets on and gets the milk flow going. That might help. Or maybe the breast is flowing just so fast, the baby's going suck, suck, suck and getting drowned. Those are some of the reasons why breast refusal might happen. Yeah. Bottle refusal. Oh, that's so frustrating. And that can be hard if the mother has to be away from the baby for a procedure or needs to wean for chemo or something like that. That can be really hard. The baby can maybe take in a bottle by not the mother, another parent or another carer. That can sometimes be helpful. Putting breast milk in it so it has a similar smell to the mother, that can be another option. You can fiddle with all sorts of teats and bottles, but the evidence whether one's better than the other or one looks like a breast is all stuff. So you can try different teats and things. I was told that you can cup feed babies. Most babies can manage to cup feed, but I found that so messy. That was just one of the messiest things. It's probably a short-term solution, maybe in the breast refusal. So yeah, breastfeeding, I'm sorry, I don't have a foolproof answer, but maybe another parent doing it that's not the mother, trying different size teats, using breast milk, that's probably not. The question is about domperidone. Thank you for your question. And it's about some women who, when it suggests to wean from the domperidone, because you can't just stop it, you have to gradually withdraw it. And women are saying that they actually can't withdraw the domperidone because their supply goes down and then they need to stay on it. And is there any problem with staying on it? And no, there isn't really, unless the woman is experiencing some uncomfortable side effects like stomach upset, dry mouth, sweating, those kind of things, and the side effects aren't bothering her, there probably isn't a problem to stay on it until she's ready to stop it. But the guru on, I can send you a link of the guru on all the evidence on domperidone. It's actually getting more and more of it. So they're saying that you can stay on it a bit longer. But it depends on the woman, doesn't it? Whether she wants to or not. The question was women who are getting their information from overseas advised to take much higher doses of domperidone, and have I seen that? Yeah, I've seen some patients be given 20 milligrams TDS or more, 30 milligrams TDS of domperidone plus the metoclopramide as well. So yeah, no, the Mother Safe are involved in looking up all the data for me in making that policy. And when I found the therapeutic guidelines, I found that really useful as well. So yeah, the evidence just doesn't support increasing it above what we are, and the more side effects are reported if you increase it. So.
Katy, there's one more question online, and we might make that the last question, I think. It's just about women with small breasts and supply problems. Besides expressing and besides domperidone, are there any other tips that you have, including are there any herbal things that are helpful?
I don't know if you've heard fenugreek. There's a study now about all the things that mothers are turning to in the community to increase their milk supply, and the list is fenugreek, booby bickies, brewer's yeast, domperidone, and they're getting it all. So the domperidone is probably the best evidence we have. The fenugreek is actually not showing a lot of evidence if it started later. It's actually working in the beginning, early on. And there's more side effects with that. There's a list a mile long on side effects for fenugreek and contraindications for patients. It has some interactions with heparin, and a lot of our women go home on Clexane, which is a worry. So my tips for mothers who are experiencing low supply is the age-old: the more you feed, the more you make. The more you remove the milk, the more you make. Is the diet supportive, nutrition support? Is she resting? Is she supported? Is she getting that turnaround? That triple feeding, my advice, they're triple feeding. The breastfeed, top up, express, that is an exhausting routine, and I would call it a sprint. I would do that for a short term and then reassess in a week or so. And when it works, it really works. When it doesn't, we know pretty soon that this mother is somebody that unfortunately has a low supply, and we have to cross that bridge when we get to it and talk about how we can best support any breastfeeding and support that breastfeeding relationship, and commend her on all the effort that she's done. Thank you.
Yes, thank you so much, Katy. It's such a relevant topic for us in general practice, and I think the volume of questions really reflected that. Thank you. So
That's it for today. So just, yes, thank you to all our speakers and thanks for everyone joining us here and online. Remember to complete the online survey. There's one in the chat for those who are online, or it'll be an email that will be sent to you as well, or there's one in your pack for people who are here. The next year's calendar will be released early next year. That's it. Have a good rest of the weekend. The calendar for education events for next year. Yeah. Thanks, everyone. Enjoy your weekend.